Morning, everyone. The topic of my presentation is emergency treatment in case of epilepsy, and my moderator is Dr. Shobit. Now, in this presentation, we'll be studying about the acute management of seizure, serial seizures and cluster of seizures, status epilepticus, types of status epilepticus, drugs used in status epilepticus, and pseudostatus epilepticus. Introduction. Emergencies in epilepsy may be encountered in the home, en route to a nearby hospital, in the emergency department, in the hospital, or in an intensive care unit. Adequate and effective treatment delivered in a timely fashion is crucial to the successful management of these patients. Here we'll be studying about acute management of the single self-limiting seizure and serial seizures and of status epilepticus. Acute management of seizure. If the seizure is likely to occur in any particular situation, for instance at school, work, etc., it is best to warn those in contact, the fellow students, workmates, associates, supervisors, etc., as the impact of a sudden epileptic seizure is all the greater if unexpected. Major attacks are frightening to onlookers, and the commotion caused is lessened with prior warning. Convulsive seizures are almost always short-lived and do not require immediate medical treatment. The sufferer should be made as comfortable as possible, preferably lying down or ease to the floor if seated. The head should be protected and tight clothing or neckwear released. No attempt should be made to open the mouth or force anything between the teeth. After the convulsive movements have subsided, roll the person into the recovery position. Check that the airway is unobstructed and that there are no injuries requiring medical attention. When fully recovered, the patient should be comforted and reassured. An ambulance or emergency treatment is required only if there is a serious injury or the convulsive movement is longer than 10 minutes, the patient does not recover consciousness rapidly, and if the seizures reoccur. Non-convulsive seizures are often less dramatic but can still be frightening to the onlookers. Again, little can be done to hasten the resolution of the attacks, which will resolve spontaneously. If consciousness is not lost, the patient should be treated sympathetically and with the minimum of fuss. Confusion is usual after a convulsive attack and during and after a non-convulsive attacks. During these periods of confusion, it is necessary to prevent injury or danger, for instance, from wandering, at the same time minimizing restraint, which often exacerbates the confusion and causes agitation or occasionally violence. Emergency anti-epileptic drug therapy is needed in convulsive attacks only if the convulsions persist for longer than is customary for the individual patient or when this is unknown for more than 10 minutes. A fast-acting benzodiazepine drug can be given. Diazepam is administered either intravenously or rectally. Intravenously, it is given at a rate not exceeding 2 to 5 milligram per minute using a diazimals formulation. Rectal administration can also be given either as intravenous preparation infused from a syringe via a plastic catheter or as a ready-made proprietary rectal tube preparation, Stesolid. Diazepam suppository should not be used as absorption is slow. Adult bolus intravenous or rectal dose in status is 10 to 20 milligram, and in children, the equivalent bolus dose is 0.2 to 0.3 milligram per kg. Alternatively, we can give midazolam, lorazepam, or paraldehyde. So these are some initial steps in the pre-hospital management of seizures and status epilepticus. First, we have to see airway, breathing, and circulation. Place in left lateral decubitus position and remove any foreign objects from the mouth, that is dentures. No need for spinal precautions. Pulse oximetry and supplementary oxygen. Then suction, bag wall mask or a secure airway as indicated. Cardiac monitoring is to be done. Insert peripheral intravenous line. Glucometer. If the glucose is less than 80 milligram per deciliter, then administer 100 milligram of thiamine followed by 25 to 50 gram dextrose 50%. Benzodiazepine administration is based on the availability. Now, serial seizures and clusters of seizure. Serial seizures are those that reoccur at frequent intervals with full recovery between the attacks. In some patients, such seizure clusters occur on a regular basis, for instance, around menstruation. In certain individuals, seizures occur only in clusters. The management of individual seizures in a small cluster is no different from that of an individual attack. If seizure clusters are common, acute therapy after the first seizure can be given in an attempt to prevent the subsequent attacks. Clobazam 10 to 20 milligram is a common choice given orally, and this will take effect within 1 hour. If seizure, either single or clusters, occur at a predictable times, prophylactic treatment can be given for few days with intermittent oral clobazam 10 to 20 milligram per day or astazolamide 250 to 500 milligram per day. Now, status epilepticus. Status epilepticus is a condition in which epileptic activity persists for 30 minutes or more, causing a wide spectrum of clinical symptoms and with a highly variable pathophysiological, anatomical, and etiological basis. It is not simply a rapid repetition of seizures, but a condition that has distinctive pathophysiological feature. There are a set of syndrome called boundary syndromes, which are prolonged states in which the symptoms may be due to ongoing underlying epileptic activity. These include some cases of post-ictal confusion, periictal psychosis, and behavioral disorders, and states in which there is evidence of electrographic status without overt seizure activity. This is the classification of status epilepticus. It has been broadly divided into status epilepticus occurring in the neonate and infantile epilepsy syndrome, then status epilepticus occurring in childhood, status epilepticus occurring in both childhood and adult life. Then there are some boundary syndromes, and these are the cases in which it is not clear to what extent the continuous epileptiform electrographic abnormalities are contributing to the clinical impairment. So this is the pathological pathophysiology of status epilepticus. Basically, in status epilepticus, the GABA, which is an inhibitory neurotransmitter, it gets inhibited. So there is continuous firing of the neurons occurs and discharges occur, which leads to continuous seizure activity. And glutamate, which is an excitatory, its activity persists. So due to the inhibition of the GABA, and finally, due to excess of excitation, the GABA, which is a inhibitory neurotransmitter, it becomes unresponsive. So continuous firing occurs and the seizure activity continues to go on. And there are clinical stages of seizure: acute seizure, early or impending status, established, and then refractory status epilepticus. So the highest mortality rate, it is found in malignant status epilepticus. Status epilepticus and neuronal damage. Neuronal damage likely results from a combination of systemic complications as well as intrinsic injury produced by persistent neuronal hyperactivity. Animal and human studies show elevation in markers of neuronal injury after non-convulsive seizures and status epilepticus, including elevated neuronal specific enolase levels and hippocampal atrophy. A small but increasing pool of evidence from critically ill populations has shown that electrographic seizures activity contributes to secondary brain injury or worsening the neuronal damage. Tonic-clonic status epilepticus can undoubtedly cause neuronal damage, although the damage is more likely to depend on the site of cerebral origin of the epilepsy, its severity, and the clinical context. Before the development of status epilepticus, it is preceded by a premonitory phase. During this, epileptic activity increases in frequency or severity from its habitual levels. This clinical deterioration is a warning of impending status, and urgent therapy at this stage can prevent a full-blown status. Treatment at this stage also prevents the neuronal damage. At the onset of status, the attacks typically take the form of discrete tonic-clonic seizures. The motor activity then becomes continuous, then the jerking becomes less pronounced, and finally ceases altogether. This is the stage of subtle status epilepticus, by which time the patient will be deeply unconscious. So first of all, we'll be studying about the tonic-clonic status epilepticus. It is defined as a condition in which prolonged or recurrent tonic-clonic seizures, it persists for 30 minutes or more. It commonly occurs in children, mentally handicapped, and in those with structural cerebral pathology, especially in the frontal lobes. It can be precipitated by drug withdrawal, intercurrent illness, or metabolic disturbances, or the progression of underlying disease, and is commoner in symptomatic than in idiopathic epilepsy. Most of its cases, however, develop de novo, and in such cases are almost always due to acute cerebral disturbances. The common causes are cerebral infection, trauma, cerebrovascular disease, cerebral trauma, acute toxic or metabolic disturbances, and childhood febrile illness. Alpers disease is an uncommon cause of acute status that may be exacerbated by valproate therapy. So the physiological changes that occurs in tonic-clonic status epilepticus in phase 1, the cerebral metabolism is markedly increased. Then there is massive increase in the cerebral blood flow and delivery of glucose to the active cerebral tissue is maintained. Then systemic and cerebral lactate levels rise and profound lactic acidosis occurs. Endocrine changes, it leads to initial hyperglycemia. Blood pressure also rises. Autonomic activity, it leads to sweating, hyperpyrexia, bronchial secretions, salivation and vomiting, and adrenaline and non-adrenaline release. In the phase 2, compensatory physiological mechanisms begin to fail as the seizure activity continues. Hypotension develops as a result of seizure-related autonomic and cardiorespiratory changes and drug treatment. There is a fall in the cerebral blood flow and cerebral metabolism. Ischemic or metabolic damage occurs. The hypotension can be greatly exacerbated by intravenous antiepileptic drug therapy, especially if the infusion rates are too fast. Then the other common problems that occurs in status are hypoxia and cardiac arrhythmias. Intracranial pressure can rise dramatically in late status, and the combined effect of systemic hypotension and intracranial hypertension can result in a compromised cerebral circulation and cerebral edema, particularly in the children. There is profound hypopyrexia, pulmonary hypertension, and edema also occurs. There are also metabolic and endocrine disturbances like acidosis, hypoglycemia, hyponatremia, hypokalemia, and hyperkalemia. And others are acute tubular necrosis, renal failure, hepatic failure, and disseminated intravascular coagulation and rhabdomyolysis. So in the emergency treatment of tonic-clonic status epilepticus, the principle of treatment of status are very different from those of the chronic epilepsy. The priorities are to halt seizure activity as rapidly as possible, prevent injury, maintain cardiorespiratory function, and avoid sensory medical complications. The potential long-term side effects of medication and pharmacokinetics of chronic therapy are of no importance. So these are the general measures which are to be taken. In first 0 to 10 minutes, we have to assess the cardiorespiratory function, secure airway and resuscitate, and administer oxygen. In second 0 to 60 minutes, we have to institute regular monitoring. Emergency anti-epileptic drug therapy is to be given. We have to set up the intravenous lines. Emergency investigations are to be sent, and glucose is to be administered. And if there is lactic acidosis, it is to be treated. Then in between 0 to 60 or 90 minutes, we have to establish the etiology, identify and treat the medical complications. And in fourth 30 to 90 minutes, transfer to the intensive care, establish intensive care and EEG monitoring, initial seizure and EEG monitoring, initiate intracranial pressure monitoring, and we have to initiate long-term maintenance anti-epileptic therapy. Then emergency anti-epileptic drug treatment in the pre-monitory phase. Diazepam 10 mg is given IV or rectally. If the seizure continues, then it gets turned into early status, that is, which occurs from 0 to 30 minutes. In this, lorazepam IV 4 milligram bolus, which is repeated after 10 minutes. If seizure activity continues 30 minutes beyond this, then it is a established status. In this, phenobarbital bolus of 10 mg per kg at a rate of 100 milligram per minute is given, or phenytoin infusion at a dose of 18 mg per kg at the rate of 50 mg per minute is given. If seizure activity continues for 30 or 60 minutes or longer, then it gets turned into a refractory status in which general anesthesia with either propofol or thiopentone is given. Anesthetic continued for 12 to 24 hours after the last clinical or electrographic seizure, then the dose is tapered down. In all the above schemes, the refractory stage is reached 60 to 90 minutes after the initial therapy. And it is suitable usually for clinical hospital settings, and general anesthesia should be initiated earlier and occasionally it should be delayed. And in all the stages, we have to ensure that the patient's regular anti-epileptic drugs are administered, including any anti-epileptic drug that has recently been withdrawn or omitted. If the patient was not on maintenance therapy before the status, it should be initiated. Then there can be failure to respond to treatment. Common reasons for failure are inadequate drug treatment, insufficient emergency anti-epileptic drug therapy, failure to initiate or continue maintenance anti-epileptic drug therapy in parallel with the acute emergency therapy, Then there can be additional medical factors and there can also be misdiagnosis. These are the various complications that occurs after a tonic-clonic status epilepticus, and they are divided into cerebral complications, cardiovascular, respiratory, and autonomic complications, metabolic complications, and others are disseminated intravascular coagulation, rhabdomyolysis, fractures, and infection. Now, the second one is epilepsia partialis continua. This form of status epilepticus is defined as spontaneous, regular, or irregular clonic twitching of cerebral cortical origin, sometimes aggravated by action or sensory stimuli, confined to one part of the body and continuing for hours, days, or weeks. The first cases were reported in 1895, and he described a particular type of cortical epilepsy in 4 patients, which he named as epilepsia corticalis sive partialis continua. The seizure disorder consisted of frequent jerks continuing for years in the same part of body uninfluenced by the treatment. The condition was due to focal encephalitis with the Russian spring summer tick-borne virus. The jerks typically affect agonist and antagonist muscles with a rhythmic quality in short bursts of 1 to 2 seconds duration, alternating with quiescent phases of 2 to 4 seconds, persisting in sleep and worsening by action or stress. Jacksonian or generalized epileptic seizures are almost invariable. The clonic jerks in these can affect any muscle group. In some individuals, the jerks are confined to a single muscle or muscle group, but in others, the distribution is widespread. Agonist and the antagonist muscles, these are affected together, and the distal muscles are more commonly involved than the proximal. When widespread, the jerkings is usually synchronous and palatal myoclonus occasionally seen. The jerks are spontaneous and often exacerbated on action, startle, or sensory stimuli. They can occur single or in clusters, and some jerks recur only every few minutes and others are more frequent. Treatment in this phenytoin, carbamazepine, or phenobarbital are probably the drug of first choice, and oral corticosteroids are sometimes helpful. Dissective neurosurgical treatment can be considered in the refractory cases. Then there is complex partial status epilepticus. In this, there is prolonged epileptic episode in which fluctuating or frequently recurring focal electrographic epileptic discharges result in a confusional state. Episodes of these are usually recurrent and occasionally there is remarkable periodicity. They have highly variable clinical symptoms and the focal epileptic discharges may arise in temporal or extratemporal cortical regions. They last for days or even weeks, although typically an episode will persist for several hours. It is commonest in the adults. Precipitating factors include menstruation, alcohol, and drug withdrawal. Confusion is the leading clinical feature of complex partial status. It can fluctuate or be fairly continuous. The severity can vary from a profound stupor with little response to external stimuli, and in some cases, it can be subtle abnormalities on cognitive testing. It is the only sign. The other symptoms can be behavioral changes like aggressive, hostile, or anxious behavior, delusions, catatonia, visual or auditory hallucinations, idea of reference, paranoia, illogical responses. Then in speech disturbances, there can be aphasia, perseveration, confabulation, echolalia, and stereotyped repetitive utterance. Then there can be posturing, clonic jerks, tonic spasm, adversion of the head and eyes, and motor automatism. Then autonomic disturbances are there like blenching, flatulence, change in color, pupillary dilatation or fever, and other sensory symptoms or signs. In EEG, there are frequent spikes or spike or slow wave or spike or wave paroxysms that are sometimes widespread or focal, and also episodes of desynchronization are seen. The longer the status proceeds, the less likely is discrete ictal activity to be noticeable. Neuroimaging will often show an underlying structural lesion, but transient focal abnormalities suggestive of vasogenic cerebral edema are occasionally seen on X-ray, CT, or MRI scans, which disappear when the seizure activity resolves. The prognosis of complex partial seizure is good. It is not usually life-threatening and resolves with oral or intravenous therapy. There is a strong tendency for it to reoccur, however. It is an EEG which shows a complex partial status epilepticus. Then there is typical absence status. It is a non-convulsive status occurring in the syndrome of idiopathic generalized epilepsy. It occurs only in patients with idiopathic generalized epilepsy. Then it occurs in about 3 to 9% patients with a history of typical absences. The attacks can reoccur and can last for hours or occasionally for days. The precipitating factors are withdrawal from a medication, hypoglycemia, hyperventilation, flashing of bright lights, sleep deprivation, fatigue, stress, and grief. The principal clinical feature of typical absence status is clouding of consciousness. This can vary from slight clouding to profound stupor. Then there can be slowed ideation and expression and deficits in activities requiring sustained attention, sequential organization, and spatial structuring. Immobility, mutism, simple voluntary actions performed only after repeated requests, long delays in verbal responses, and monosyllabic and hesitant speech is seen. The patient is in an expressionless, trance-like state with low responses and a stumbling gait. Motor features occur in 50% of the cases, which includes myoclonus, atonia, rhythmic eyelid blinking, quivering of the lips, facial grimacing, and smiling. Then there are also atypical absence status. These are the status that occur largely in secondarily generalized epilepsy of the Lennox-Gastaut type and also in other patients with compromised cerebral function and transitional cases. Atypical absence status is often preceded by changes in motor activity, mood, or intellectual ability for hours or days before the overt seizure develops. Once atypical absence status has developed, it tends to fluctuate and minor motor, myoclonic, or more typically tonic seizures interrupt but do not terminate an episode. In some of the patient, the mental state fluctuates gradually in and out of this ill-defined epileptic state over long periods of time, with less distinction between ictal and interictal phases. It is more likely to occur if the patient is drowsy or understimulated, and it is thus important not to over-medicate these patients. The EEG during atypical absence status may show continuous, irregular, slow 2 Hz spike or wave, or hips arrhythmia, or more discrete ictal patterns. This is the EEG which shows atypical absence seizures status. For the treatment, diazepam 0.2 to 0.3 mg per kg, clonazepam 1 mg, or lorazepam 0.07 mg per kg is given, and it is repeated if required. If this is ineffective, intravenous chlormethiazole, phenytoin, or valproate may be needed. Although these are seldom life-threatening and aggressive intravenous therapy is therefore seldomly required. Oral therapy with valproate, lamotrigine, or felbamate is sometimes useful in typical or atypical absence status. Then the drugs which we commonly use in status epilepticus, the first one is diazepam. It is mainly useful in the premonitory or the early stage of status. Although it has a rapid onset of action, it is highly lipid soluble and thus it has a short duration of action after a single injection with a strong tendency for seizures to relapse after an initial control. And the usual dosage which we give is IV bolus, undiluted 10 to 20 milligram in adults and 0.25 to 0.5 milligram per kg in children. And the rate should not exceed 2 to 5 milligram per minute. And its rectal administration can also be done. The second drug is midazolam. It is also can be used in premonitory or early stage of status. It has one major advantage over diazepam is that it is rapidly absorbed by intramuscular injection. And the usual dosage which we give, this drug midazolam, we give by intramuscular route only. Rectally, we give 5 to 10 milligram in adults and 0.15 to 0.3 milligram per kg in children. And this can be repeated once after 15 minutes. IV bolus of 0.1 to 0.3 milligram per kg at a rate to not to exceed 4 milligram per minute, which can be repeated once after 15 minutes. Then there are paraldehyde. It is still has a useful place in premonitory and early status as an alternative to diazepam, especially in situations where facilities for resuscitation are not available. Its usual dosage, it is given rectally or it can be given IM, 5 to 10 ml, diluted by the same volume of water for injection in adults and 0.07 to 0.35 ml per kg for children. Then clonazepam. The main indication of clonazepam in status is as an alternative to diazepam in the early status. It has a similar onset of action, a longer duration of action, and a lower incidence of rate of late relapse. Usual dosage is 1 to 2 milligram bolus injection over 30 seconds in adults and 250 to 500 gram in children, which can be repeated up to 4 times. Lignocaine. Lignocaine is given in early status only as a bolus injection or short IV infusion. The main disadvantage of lignocaine is that its anti-epileptic effects are short-lived and seizures are controlled for a matter of hours only. The drug is thus useful only while more definitive anti-epileptic drug treatment is administered. And it is also given by intravenous bolus injection of 1.5 to 2 nanogram per kg, usually 100 milligram in adults, and the rate of injection should not exceed 50 mg per minute. Lorazepam, it is the drug of choice in the early state of status given by IV bolus injections, but the main disadvantage of lorazepam is a stronger tendency for tolerance to develop, the drug being usually effective for about 12 hours only. It is given by IV bolus of 0.07 mg per kg, repeated after 10 minutes if necessary. Phenytoin. Phenytoin is highly effective medication for established stage of status. The drug has a prolonged action with a relatively small risk of respiratory or cerebral depression and no tendency for tachyphylaxis. Its main disadvantage is the time necessary to infuse the drug and its delayed onset of action. It is for this reason that it is often given with diazepam, the combination theoretically providing a rapid onset and long-lasting anti-epileptic effect. And in adults, it is given by IV infusion, 15 to 18 mg per kg. Phenobarbital. It is used at stage of established status as a first-line alternative to phenytoin. It has a rapid onset and long-lasting action and can be administered much faster than the phenytoin. Risk of drug accumulation and inevitable sedation, respiratory depression, and hypotension is there. This we give by IV loading dose of 10 mg per kg at the rate of 100 milligram per minute. Usual adult dose is 600 to 800 milligram, followed by a maintenance dose of 1 to 4 milligram per kg in adults. Thiopentone, it is usual choice for barbiturate anesthesia. It is highly effective anti-epileptic drug with additional potential cerebral protective action. Its usual dosage is 100 milligram to 250 milligram IV bolus given over 20 seconds with further 50 milligram boluses every 2 to 3 minutes until the seizures are controlled. Isoflurane, it is the drug of choice for inhalational anesthesia in status and has significant advantages over other inhalational anesthetics such as halothane or enflurane. Its usual dosage is inhalation of isoflurane at dosages producing end-tidal concentration of 0.8 to 2% with the dose titrated to maintain a burst suppression pattern on the EEG. Then propofol, it is a good anesthetic with excellent pharmacokinetic properties. In status, it has a very rapid onset of action and rapid recovery. Usual dosage is 2 milligram per kg bolus, repeated if necessary. Then due to propofol infusion syndrome can occur if more than 5 milligram per kg per hour for longer than 48 hours of propofol infusion is given, and particularly it occurs in the patients who have head injury. So in this diagnostic criteria, greater than 6 hours after initiation of propofol is creatinine kinase more than 2000, triglyceride more than 500, progressive lactic acidosis more than 2.5 millimole per liter, plus bicarbonate are less than 20 millimole per liter after more than 6 hours after propofol infusion. This is the generalized convulsive status epilepticus protocol which we usually follow. Then anti-epileptic drug trial for the diagnosis of suspected non-convulsive status epilepticus. Its indication is rhythmic or periodic focal or generalized epileptiform discharges on EEG with neurological impairment. Contraindications are patients who are heavily sedated or paralyzed, patients who have a clear reason for their level of consciousness. We have to monitor EEG, pulse oximetry is to be done, blood pressure, electrocardiography, respiratory rate, anti-epileptic drug trial, sequential small doses of rapidly acting short duration benzodiazepine such as midazolam 1 mg per dose or non-sedating anti-epileptic drugs such as levetiracetam, valproate, phenytoin or lacosamide is to be given. Between doses, repeated clinical and EEG assessment is to be done. Trial is stopped after any of the following. If there is persistent resolution of the EEG pattern, definite clinical improvement is there, respiratory depression, hypotension, or other adverse effects occur, a maximum dose is reached, such as 0.2 milligram per kg midazolam, though higher may be needed if on chronic benzodiazepine. Then there is pseudostatus epilepticus. It is a condition in which repeated or continuous seizures occur, which are psychogenic in origin and which resemble, at least superficially, the convulsive status epilepticus. The motor movements do not have the classical features of convulsive seizures but fluctuate in intensity, frequency, or distribution as the status proceeds, often influenced by emotional external factors. Vocalization is common as a bizarre behavior, explosive emotional expression, and resistance to examination. Incontinence, tongue biting, and cyanosis do occur but are less common than in true status. There is often a long history of psychiatric or personality disorder, often with hysterical features and previous episodes of pseudostatus or other non-organic illnesses. The epilepsy history is usually atypical, showing an odd pattern of seizures over time, an inconsistent response to treatment, and repeatedly normal interictal EEG. An EEG during the episode will definitely confirm or refute the diagnosis if there is a clinical doubt. A few patients exhibit both true epilepsy and non-epileptic seizures, and occasionally an episode of pseudostatus will follow a true tonic-clonic seizure. Most of the patients have no formal psychiatric diagnosis, but in others, there is evidence of malingering, psychopathic disorder, a history of a sexual abuse, or neurotic personality disorder. So, to summarize all this, seizures and status epilepticus are epilepsy emergencies with high morbidity and mortality. Early treatment is crucial, and the identification of an underlying etiology informs both continued treatment and prognosis. How aggressively to treat is controversial, but timely EEG can be useful for diagnosis, management, optimizing treatment response, and determining prognosis in these patients. Refractory conditions can be quite complicated with limited evidence-based guidance, but treatment should not be restricted by nihilism even in the most prolonged cases, especially if there is not widespread irreversible brain injury. These are my references. Two. You showed in the presentation? Yes, sir. Yes. Uh, Ma'am, it has a, ma'am, it acts, its onset of action is rapid and it is the, ma'am, it can act rapidly because at that time it is an emergency situation. So we need a drug that acts rapidly. So mostly diazepam is used. So diazepam, question is valid. Why do we use diazepam? I mean, first is diazepam is fine. And you said rapid onset of action. Yeah, that is. What is the stay use of the spectrum? First part, maybe or
What if there is overdose of antiepileptics? Then the patient will into deep sedation. Patient goes into deep sedation because of override. So there is a difference. Is there benzodiazepine interval? Like your hypertensive या हाइपोटेंसिस ज्यादा दे दिया जैसे लैसिक सिग्नल हाइपोटेंसिस नॉट we have stabilized the okay, so even if the patient goes into overdose, you are treating epilepsy, your main aim is at that time is to break the status, right? Now that is cured, but the patient is gone into sedation with or depression, you need to minimize it, shut it down. So if you must then just know you can reverse it. Respiratory depression is long, then safety also does the right. So faster onset safe. Is safer, their effect is reversible. And it can be titrated. Okay, एंटीएपिलेप्टिक का डोज टाइमली लेता है, टाइट्रेट करना मुश्किल है और आप एकदम से रिवर्स ठीक है प्रैक्टिक वो ड्रग ड्रग इंटरेक्शन वो एक अलग टैकीफाइलेसिस क्या होता है कि फिनोबार्बिटॉल में टैकीफाइलेसिस क्या है आपको जो प्रेजेंटेशन ना उसके टर्म्स आप जो भी प्रेजेंटेशन होता है उसमें टर्म्स जो भी है उसके मीनिंग को आपको जानकारी है टैकीफाइलेसिस फार्म वाले भी है ना फार्म वाले भी वेरी गुड सही कहा तुमने वीडियोस में शो वो भी करते हैं और अपना जो है जैसे खास करके किताबों वालों की और अपना मेंशन करता है बट ये है कि आपकी एफिकेसी कम हो जाती है जैसे बताया ना फिनोबार्बिटॉल में यूज है ना दैट इट डजंट टेक इट कंपेयर्ड टू फेनिटोल
Central. It has a prolonged action and relatively smaller risk of respiratory or cellular depression, and it has no tendency of taking.
फेनिटोल is preferred that way. So very good anti-epileptic IV worldwide. This common. Have you seen status patients? Emergency. Flexibility, applying to medicinal media reaction. Caesar applying the bottle because it's safer in Vegas. So ठीक है हम लोग psychiatrist से जब भी जाओ सभी you can get better safety. What about alcohol withdrawal? should we not give penicillin? Should we give penicillin? Drug of choice. Should we give penicillin? Control, it will not control. Right? So, different in some way. Sometimes it's not that bad. It's drug of choice. Because it will also give it on that thing on the job. Safety wise, you can safety cases. You can do very well when you are public. In ICU, you can give it. To start the seizure. Does your medication change with the type of seizure?
Mostly, sir, these are polyclonic type of status only. So in
You
that,
understood my
sir,
question?
yes,
So, answer this. Does the medication change with the type of seizure? Most common तो GTCS है उसका मैं रट दिया था एग्जामिनर क्वेश्चन नहीं कर रहे क्वेश्चन कुछ और है एग्जामिनर के नहीं पता कोई बात you know you are presented is the medication like if there is absence continuous partialis etc does the last में आपने चार्ट दिखाया status को दिखा वो that is what GTCS था
yes, sir.
that were all GTCS
So GTCS.
GTCS is the most common but the question is like does it change the medication change with like if it is partialis continuous then partial अगर
So partialis continuous is mostly phenytoin, paracetamol, phenobarbital are probably the drug.
yes.
And so oral corticosteroids are also sometimes helpful.
Absolutely.
So in absence, so diazepam.
You should use designation without purpose is that it is education. Purpose is that you read, study, even if you present 4 slides on your own. These I'm standing multiple. Standing multiple is Rupali. So, so if you learn whatever you learn, okay. So whenever you made a presentation, okay, after the presentation is made, you spend half an hour, 1 hour to the possible questions that can come. Okay, आप चाहे तो बना लिया करो, ठीक है मैं तो कहता हूँ प्रेजेंटेशन के बाद में 3-4 क्वेश्चन रख ही दिया करो क्वेश्चंस फॉर डिस्कशन ठीक है कि दीज आर द क्वेश्चंस दैट कैन बी डिस्कस या प्रेजेंटेशन के शुरू में क्वेश्चन ये क्वेश्चंस हैं और ये मैं अपने प्रेजेंटेशन में कवर करने की कोशिश what are the types of continuous epilepsy, what is the management, and then you will ठीक है it is not expected that you will know the dose of every medicine या पर मेजर है उसका तो बुलवाना से डाइजिपाम का डोज क्या है पहला क्या डोज है डाइजिपाम फर्स्ट स्टेटस आ गया डाइजिपाम लेना है पेशेंट को कितना दो अभी बोला तुम दे रहे हो ना 0.2 मिलीग्राम 10 से नीचे है 20 है 20-30 मिलीग्राम .2 अगर लोगे तो 10 kg में अगर 2 मिलेगा ठीक है और 60 kg में 12 around 10 milligram you can go for 10 milligram is not that big a deal अगर 50 kg का कोई है उसके लिए 10 मिलीग्राम सफिशिएंट इससे ऊपर है तो यू कैन गो फॉर ठीक है राजन पे मिलीग्राम पर केजी के हिसाब से एक थियोरेटिकल एक प्रैक्टिकल है प्रैक्टिकल तुम 10 मिलीग्राम दे वेट करते हैं 10 मिलीग्राम अगर ज्यादा हैवी पेशेंट ठीक है फार्मा वाले कौन कौन है डाइजिपाम ठीक है डाइजिपाम जो है उसका अगर आईवी देते हैं 10 मिलीग्राम 20 मिलीग्राम, उसकी बायोअवेलेबिलिटी कैसे वेरी करती है? प्लाज्मा कंसंट्रेशन एकदम से देगा बढ़ जाएगा, फिर क्या होगा? क्या होता है? कहाँ चले जाता है ऐसा? कहाँ पे? नहीं, रिसेप्टर तो ब्लड में रहता है, कहीं प्रोटीन में अटैच होता है, कहाँ पे जाता है? प्लाज्मा में रहता है। प्रोटीन बाउंड रहते हैं अगर ड्रग फैट सॉल्युबल है, फैट में डिसॉल्व रहते हैं, उनसे प्लाज्मा राइज रहता है, फिर वो उनसे रहता है, फिर धीरे धीरे करता है। पढ़ा नहीं, पढ़ा है? पढ़ा है किसी ने? होता है नहीं होता? नहीं होता? बता दो, हो सकता है मैंने तो बहुत पहले पढ़ा था। हो सकता है कोई रिसर्च करता, आप बताओ मुझे तो सेम बात। लोराज़ेपाम, जो लोराज़ेपाम का लिखा हुआ है ना इसमें, लोराज़ेपाम की हाफ लाइफ कितनी होती है? डाइज़ेपाम की कितनी होती है? ज्यादा होती है। आपने देखो ना, उसमें लिखा है लोराज़ेपाम हैज अ लॉन्गर एक्शन। सर, लोराज़ेपाम में लॉन्गर एक्शन, ठीक है, stronger tendency to tolerance, it lasts for 12 hours, ठीक है। लोराज़ेपाम में आता है, लोराज़ेपाम नहीं जाता है, वो प्लाज्मा में रहते तो उसका कर वैसे रहता है। तो बेस्ट थिंग इज टू गिव, if you have patient in that is going to give diazepam plus Veritran, that is the best, right? Veritran का dose देखो, Veritran का dose, Veritran का dose कितना हो गया?
15 to mg per kg IV
15 to,
infusion.
इसका कार्बोमोजिकिन का
15
लगभग सेम है, 15 ग्राम, ओके, केजी बॉडी वेट है ना, आईवी इंफ्यूजन, ठीक है। नॉट मोर देन 50 मिलीग्राम पर मिनट, तो इंफ्यूजन मिलेगा स्लो। तीनों बार बताओ, देखो इसीलिए ना स्लो इंफ्यूजन मिलता है। तीनों बार बताओ। हाँ,
So IV
वही तो करिए। ओके, ठीक है, जाओ। हाँ जाओ, तीनों बेटे बोला। मैं सोच रहा था, मुझे लगा तो सीधी है इनकी एग्जाम रूटीन, मैं देखा था कि हम में से किसी की है। डिड यू नो? ठीक।
loading dose of 10 mg per kg at a rate of 100 mg per minute.
लोडिंग डोज ऑफ
10 mg per kg at a rate of 100 milligram per minute.
यूसी कैन गिव इट मच फास्ट, है ना, यू कैन गिव इट इन मच फास्टर, इट विल टेक द टाइम लगेगा 15 मिनट, और नेक्स्ट इंफ्यूजन। But we give penetrant infusion with diazepam. That is the first thing. Most of the patients will be okay with that. We can give diazepam also. Diazepam भी हो जाता है, ज्यादातर स्टार्टर प्रोटीन में चलता नहीं, ठीक है, तो कई लोगों में चलता है, ठीक, जो अल्टीमेटली you have to shift the ICU and then you require the ICU set. Plus penetrant पर तुमको तुम्हारा काम है मिनिमाम प्लस डायजेपाम, शिफ्ट the ICU, ठीक है। फिर उसके बाद में कीप ऑन एस्केलेट, डायजेपाम यू कैन, diazepam you can give add on, फिर अल्टीमेटली यू कैन गो फॉर जी एनेस्थीसिया, ठीक है। नॉट मसल रिलैक्स, मसल हमको मसल रिलैक्स नहीं करना, ठीक है, तो वी नीड टू ब्रेक द सीजर, सो सेंट्रली एक्टिव, ओके, सेंट्रली एक्टिव विटामिन वगैरह इसमें नहीं काम लगेगा, यू हैव टू गिव प्रोपोफल, ओके, सो यू कैन गिव इंफ्यूजन ऑफ प्रोपोफल, मिडाजोलम इंफ्यूजन, कुछ भी सर, लेविट जो रिसेंट एडिशन है वो लेविट्रोसेटाम इंजेक्शन. लेविट्रोसेटाम also you can give up to 2 grams in recent cases. Okay, so the correspond area full-time area. The advantage of levetiracetam is that sedation नहीं होता और drug drug interactions का बहुत कम है, काफी safe. Many neurologists prefer for add-on to this rather than trying to submit valproate या levetiracetam या try levetiracetam first. Okay. That is levetiracetam, you know, जो why it has got up because of its safety, but for us psychiatrists it is not that because जो है उसके adverse effects बहुत ज्यादा है, agitation, psychosis. सीजर में आएगा तो क्या देना चाहिए, किसी को रिस्पॉन्स देते हैं देना चाहिए, जब रह गया उसको तो इतना तक रिस्पॉन्स में भेज देते हैं. Seizure is a manifestation of cerebral activity. It can reoccur. तो मतलब ये जो हाइपर सिंक्रोनस हुआ एक बार तो फिर नथिंग कि आपने उसकी मीन से एड्रेस कर दिया. सीजर आया, सीजर हाई प्रोटेक्टिव मैकेनिज्म सारे न्यूरॉन्स फायर करते हैं एंड देन दे गो इनटू रिफ्रैक्टरी स्टेज. न्यूरॉन होता है ना फायर करता है, फिर आफ्टर फायरिंग इट गोज इनटू रिफ्रैक्टरी स्टेज. इट डज नॉट फायर ड्यूरिंग दैट. सो वो एक ब्रेन को प्रोटेक्ट करने के लिए है कि वो जो हाइपर सिंक्रोनस चीज है तो वो हो रही है तो ब्रेन जैसे शी सेड दैट दिस विल बी harmful for the brain. So एक बार सीजर आया so everything goes into decline. क्योंकि डिसऑर्डर में वही है कि that the individual has a higher potential to go into that hypersensitive state. So you continuously keep the nerve membrane वो की फायरिंग कम एंटी के वैसे काम करती है ना. तो लोरेज़ेपाम दे देना चाहिए ताकि इट डज नॉट. और वो मेडिसिन वगैरह में अगर फेनिटोइन दे देते हैं वो एकदम से फेनिटोइन शुरू कर देते हैं, दैट इज ऑल्सो like in protocol you can give it to reduce the tendency to have. If you can use in status, so you can use here also. If in status you can give ferritin and diazepam or lorazepam. Here also you can. The main purpose is not to treat that seizure, but to prevent. And then start the treatment. It is symptomatic of the seizure. It could be like cause of metabolic side effect, the seizure could be hypoglycemia, etc. So then you treat the underlying cause. If nothing is there, like a seizure disorder, okay, so, but you have to prevent the recurrence. See? Okay. You want to add? क्या होगा ये फर्स्ट स्टेटस ओवर क्या दें कितना 50 मिलीग्राम पर केजी बॉडी वेट. ठीक है, नॉट मोर देन 50 mg इन अ मिनट. तो यहाँ पे तो आईवी देखते तो 10-15 मिनट में देते हैं, 10-15 सेकंड देते हैं. इट इज बेटर टू उसको रिड्यूस करने का रेट ऐसा होता है कि अगर आप जो है जैसे कि आप लोराज़ेपाम भी इंफ्यूजन दे तो NaCl उसको डिजोल्व कर लो बड़े वाले इंजेक्शन. ठीक है, और फिर उसको इन्फ्यूज करोगे तो अपने आप उसका कम हो जाएगा. या आप जैसे मैंने कहा ना साइड आर्म से, जैसे आपने आईवी लाइन दे रखी है साइड से उसका इन्फ्यूजन आप स्लोली ड्रॉप करके जा रहा है उसके साथ, ऐसे कर सकते हो. या उसको डिजोल्व करके ज्यादा ताकि वो एकदम से आ जाए. ठीक है, पहले ट्राई डाइजेपाम 10 मिलीग्राम से 50 मिलीग्राम 50 kg तक वेट बॉडी वेट हो तो वो 2 से 3 तक आ जाएगा, 0.2 to 0.3 मिलीग्राम तक आ जाएगा. ठीक है, और नहीं रुकता है तो लोराज़ेपाम दे सकते हो. शिफ्ट टू आईसीयू देन यू स्टार्ट विद लोराज़ेपाम. ठीक है, most of the patients will respond to the lorazepam. Some will require some require this. I've seen a patient where like ultimately had to be done where only I got that levetiracetam. But you will not see in psychiatric. usually in secondary thought. The irritant is there. Okay, so you can see if there are two things, somebody sees a disorder, has neurocystic sarcosis or irritant, so already is having epilepsy, a tendency to have seizures, and then you have an irritant tumor or a metabolic cause or say NCS, which keeps on increasing, so you can go to status. About the presentation, good presentation, you presented well, but understand it first. Secondly, जो हम सब बोल रहे हैं इसका प्रिंट आउट ले लो, प्रेजेंटेशन बनाओ, एक बना दो एक दिन पहले, ठीक है, इसका प्रिंट आउट ले लो पढ़ने के लिए और इनको सबको बुलेट पॉइंट्स में करो. You know what is used at the stage of established status as a first line alternative to therapy. इसको ब्रेक करके दे दो. Phenobarbital is a alternative to therapy. बोल तो पूरा ठीक है, ब्रेक कर दो. रैपिड ऑनसेट, लॉन्ग लास्टिंग, एडमिनिस्टर इज मच फास्टर. ठीक है, 3 सब हेडिंग से ब्रेक कर दो. ठीक है, फिर इस स्लाइड के तुम 3 स्लाइड बना सकते. फिर डोजेज का एक स्लाइड बना दो, डोजेज 10 मिलीग्राम पर केजी. ठीक है, तो ब्रेक इट इनटू दिस थिंग एंड जो है डोंट राइट कंप्लीट सेंटेंसेस. ठीक है, और रेफरेंस अगर तुम नहीं पे सब पे लिख दो या खास करके डोजेज को लेकर के और इंडिकेशन को लेकर के चार्ट, जैसे तुमने बताया कहाँ से बताया वो चार्ट, सो लिखा हो तुमने कहीं तो चार्ट. ये इससे पहले ये DCSC प्रोटोकॉल, तो ये पर ये कहाँ से दिया?
So it was a sub publication.
कहाँ से लिया? पब्लिकेशन से, आर्टिकल से?
No, so this is from Duncan.
जैसे अगर तुम्हारा 2-3 ही तुमने रेफरेंस यूज किए हैं तो एक बॉक्स को कॉपी करो, जहां जहां पे है उसको पेस्ट कर दो नीचे छोटा, बोलते समय मेंशन कर दो इंपॉर्टेंट स्लाइड्स which this flowchart I have taken from documents. Value presenting, ठीक है, ठीक है. Actually, we are placing opinion ना, तब भी हम वो अभी जिस बात हुई थी that one of the reasons रास्ता is we'll do like that. One person is in OPD or later on we can expand into others. So that person is OPD one. So he or she will not be taking indoor cases. And those in indoor can then do the work of indoor patients. will not have to rush in there. Okay. वो यहाँ पे काम करो. इसके बाद क्या अभी तो एक ही होते जाना पड़ेगा. ठीक है, वो अपना डिसाइड कर सकते. Later on, I think that once necessary, we'll have to residents who are in OPD only, they take care of OPD for 50 days. And then invitation missions, no those who take care of indoor, they take care of indoor only. Okay. That way, you people will not have to keep on the national. ठीक है, वो भी चेक करेगा. इंडोर वालों को भी टाइम लगेगा. इंडोर का काम होता है वहीं पे फाइल पूरा फाइल का डेटा आ जाएगा. 3 काम पूरा कर लेना चाहिए. ठीक है.